Looks like whoever is speaking may be muted, so you can dial *6 to unmute yourself.
Welcome. Thank you for joining us today on ASTHO's Health Opportunity Index webinar, using data to measure and address the social determinants of health. I'm Deborah Fournier, Senior Director at ASTHO's Center for Population Health Strategies. Just to share a little bit about who we are, ASTHO is a national membership organization representing the state and territorial directors of governmental public health. Our objectives today are to provide you with an overview of what the Health Opportunity Index tool is, provide some state-specific examples of the use of HOI data to better understand and advance health equity, and to share guidance and tips for those interested in developing an HOI in their own jurisdiction. Our speakers today are Rex Anson-Dwamena. He's a social epidemiologist with the Office of Health Equity within Virginia's Department of Health. And our second speaker is Chip Allen, who is the Director of the Office of Health Equity at the Ohio Department of Health. Following their presentations, we do have an opportunity for Q&A, which will give you the opportunity to ask your questions. Please type in your questions in the chat box, as Vic mentioned. So ASTHO is promoting the use of the Health Opportunity Index tool because it is a vehicle for sharing data around the social determinants of health. There is evidence that supports the connection between unmet health-related social needs of an individual, like housing or food insecurity or interpersonal violence, and connections to poor health outcomes and increased healthcare utilization. What we have also come to understand is that there is also a link among unmet health-related social needs and their reflections of larger, integrated, and overlapping social and economic structures, which we refer to as the social determinants of health, that can create opportunities or barriers for an entire community to be healthy and well. The social determinants of health include social context, built environment, and other structural and societal factors which fall outside the purview of any one single sector or agency. The Health Opportunity Index is a vehicle to compile different data sets that reflect the domains related to the social determinants of health and can help to identify what a specific community needs in order to achieve health and wellness. Today's first speaker is going to be Rex Anson-Dwamena. He is with Virginia, and he initially developed the Health Opportunity Index tool. He will be followed by a presentation later from Ohio, who developed their own version of the tool. So with that, Rex, please take it away.
Sure. Thank you so much. Thank you. And good afternoon, everyone. Like you said, my name is Rex Ford, and I do work for Virginia Health Department in the Office of Health Equity. And thanks for turning into this webinar. Well, given that the health inequities are very common in the United States and widely acknowledged, the challenge of my office was to identify actionable metrics that will help us to tell a good story and also provide understanding of the root causes of these disparities. HOI is designed, actually was designed to capture the processes of which opportunity to be healthy emerge. In other words, it's intended actually to point out a direction for specific intervention. And also not only does it point in the direction, it also assists us to identify such areas and how it can also facilitate a positive attitude towards change. HOI actually, personally, HOI has already taught me how to appreciate that place shapes opportunity. Now the slide on the screen, my office again, we have consistently reframe our question and analyze involve multi-level analysis. In other words, we have moved away from higher level like state or county level analysis, but rather drill down to the basic census tract, or sometimes lower if it needs to be. Why? Because it helps us to unmask so much information in details. Now, if you look at the slide again, if you look at it, we can actually identify which neighborhoods that are, as well as the social profile of even each individual person, where they live and what they experience. Next slide. Now, like I said earlier, if you look at this here, what we call Simpson, this is some of the theories that help us to develop the HOI. And now, it's something we call a Simpson paradox. If you do analysis at the county level, you get different results. If you disaggregate your data into census tract level or block group level, if you have the data, enough data to do that, you get different results. What that means is that aggregation of data and disaggregation of data are not linear transformation. But when you build your analysis at the lower level, you can always build up to the higher level, because that helps you to identify the pockets within your neighborhood or within your state. Next slide. Now, if you look at most Virginia, we figure that Fairfax has the lowest poverty rate. In fact, one of the counties, richest county in Virginia, 6%. But Fairfax has the highest number of people in poverty, which almost 67,700 persons live in poverty. But how do you identify this population? In other words, if you do it by county, so nothing is going on. But at the tract level, you'll be able to find the pockets within Fairfax where you should implement your policies, also target this population who need help. Now, next slide. Right. Now, the HOI was built on this Healthy 2020 model, the 5 elements. So we look at the neighborhood effect, we look at the health care access, we look at the social context, education, and economic stability. So when you go to the next slide, you will see that each of the variables we have fall under one of these domains, because we wanted to make sure that those domains actually fit this model, so that we can always have a place of reference, or say, hey, what is going on this thing based on what we know, based on the Healthy 2020 5 elements. Next slide. So what we did was in Virginia, we actually we do know that ACS, which is census data, has so much noise in them. So we extracted about 40 variables, and then we put them into 13 indices. Out of the 13 indices, we also put them into 4 buckets, which we call it the profiles. And out of the 4 buckets, we also weighted them into 1 index. So if you look at it, we have 13 variables from census. And again, all these variables are public domain, public data. They're all out there. We put them into indices because we believe those indices, based on our stakeholders' input, do affect health. So we did that, put these 30 indices, and then we put them into 4 buckets, 4 profiles, based on a statistical method, not just by just asking someone, oh, what do you think? But rather use statistical method to put them into 4 buckets. Then they were weighted into 1 index. And that's what we call the health opportunity index. So if you can see that from 13 to from over 40 variables to 13 indicators to 4 profiles to 1 index. So the 1 index is what points to a direction. That's what we call heuristic model. So if you put this on the map, it tells you where you should be looking within your state or within your neighborhood, where the problems are. And again, these are the 13 that I talk about. So we look at the education attainment, we look at population density. Why? Because we wanted to control for rural and urban. Look at segregation index. We didn't look at race, but segregation index. Population turnover, people who are coming in and those who are going out, you need to know. So if we look at Northern Virginia, for instance, the turning rate is higher because people move in and out all the time. But in the rural areas, people have a stable population. You have to control for that. So this, you have income diversity, what people call a Gini coefficient. unemployment, not unemployment, but employment accessibility. You look at the food access, workability, all those indicators, because we believe that these indicators are very important to achieve a better health. Next slide. So based on all these indicators, we put them all into one index, and it helps Virginia. Honestly speaking, we have been able to identify this population that live on this vulnerable population that have it. Again, this HOI is not meant for redlining. It is meant to target the population that we can, we can help. It's not there to say, oh my gosh, this is a redlining indicator. No, it is not, because it is not a causal model. It is the index to identify the opportunity to be healthy. So the index actually helps us to identify this neighborhood in Virginia. And in fact, if I go to the next slide, you see that what the index has done that is very very surprising to most of us, that we didn't even know that this was going on. And again, like I said earlier, these are the 4 buckets. So we have the community profile, we have the economic profile, the consumer, and awareness. Each of these profiles or the components tell a different story. So you can actually take one of these components and run with it, because it tells a different story based on neighborhood. And maybe I didn't say it earlier, but the 13 indices I showed earlier become the DNA of your neighborhood. So we can tell that which of the 13 indices actually really affect health or their contribution to health outcomes. And then to do after we could do the construction, we also want to make it a visual representation. So here on the map, you see all the dark blue areas. Those are the areas that have a very low health opportunity. Now, these areas have a low opportunity to be healthy compared to the green areas. And so here, if you have a limited resources, you know where to target. If we had done this analysis at the county level, you wouldn't see these pockets. But actually, most of the states can do this by block group level. But census tract level is what we're able to do, because that's the level that we have every data at the tract level. We could have done a block group level. But here we can see that in Southwest Virginia and Southside Virginia are the areas that we should be focusing when we have limited resources. Now, I guess some of the specific uses of HOI in Virginia will follow after this slide. And next slide. If you look at here, the HOI actually have helped us to actually show us that place matters. Where you live determines how healthy you'll be. It has taught us that there's a place in Richmond City where you'll be able to identify people that live in this area have a different health outcome compared to other areas, even though when there's a gentrification in the area. Secondly, it helps to identify the impact of the determinants of health, the landscape of the area. Again, you are able to tease out to figure out which of the 13 indices are more influential at the local level. Not only does it do that, you also have built together with our community, collaboration with all sectors, like local health district, stakeholders, policymakers, and so it has really helped us to actually bring it all together to the same table to figure out how to address this disparity in Virginia. And again, like I said, it also helps some of the businesses. So we have got businesses that have come to us and say, hey, we want to use your indicator to identify us where we should, we have a program. They're able to use the HOI to say, hey, this is where we should be going, this area. So businesses have used it. Communities have used it. Healthcare, in fact, DMAS approached us about somewhere last year. We're able to identify some of this uninsured population, not only uninsured, but some of the factors that we think affect health. And this were used by DMAS. We also use some of this HOI for practitioners in the rural areas to identify some of the social adverse conditions in these areas. And one of the agencies in Virginia have also used it to allocate funds to these localities in their area. So it's a very universal tool that does help to actually implement policies that are beneficial to this population that we are trying to address. Now, not just building a model of the HOI, you also have to calibrate your model. Just building a model is good, but it has to be calibrated. Now, life expectancy is the most robust life indicator of any healthcare. So when we did the HOI, we said we attach every death in the state of Virginia into a census tract that the pest of residents. And if you look at this graph here, it tells you that it's highly monotonic. So if you look at the people who live in a high HOI area, the low HOI area, you can see the difference in average number of years that somebody in a higher area lives compared to somebody in a lower area. So it helps to evaluate some of these areas and see what is actually going on. Actually, the burden, we are not just knowing the numbers, but the burden of the area. So indicated. So we use that to do that, to evaluate such neighborhoods. And again, this is an ecological model. Therefore, it's the ecology of it, not individual person who lives there, but people that live in that neighborhood, because place matters. And we also use that Office of Chronic Diseases in the VDH also approach us to do that. And we did the same thing here. I showed you. You can see the rate of hospitalization of diabetes for people who live in the HO higher area to those who live in the lower area. The same trend you see. The same trend you see. So far, every health outcomes that we have done with the HOI shows a similar pattern, except opioid. We have not been able to be successful with opioid. We did that here, and here we did a general one, the state of Virginia, not by census tract, the state of Virginia. You realize that the 4 components I showed you earlier, the economic or consumer profile was more influential compared to the environmental. So this was done for the Office of Chief Examiner. Therefore, they were able to figure out some of the policies that they have to implement to address the opioid prescription opioid crisis in Virginia. So just able to say another question was, what do we do now? The question is that if we make changes to, let's say, education, affordability index, job access, just by 10%, how much, what do we do? It shows that we will reduce this by 12%. Now, we move more into 80 on 10%, that's 4%, and
Rex, this is ASTHO. Your line is breaking up. I wonder if you are in one place, or Vic, do you know if there's another issue going on?
No, it doesn't seem like there's another issue going on. If it continues to break up, you may need to call back in from a landline if you have one around.
Yeah, Rex, we cannot hear you. We can only hear spots of your comments. Can you call back in?
Sure.
Thank you. We appreciate the patience of everybody on the line while we work this out.
Yes, I'm continuing, yeah.
Great.
Okay. So the other uses of the HOI is also a pool safety intervention. So we have used the index to be able to identify the pool safety for drawing, submission, and also pool-related injuries in the state of Virginia. So that has been used to evaluate. In fact, actually, there's a regulation going on the pool safety in Virginia, and that's based on what we did with the HOI. Again, we have also used the indicator also to address some of the rural programs in Virginia. HESA's a program like FLEX, program also SAW, as well as the other connected program waiver, where we were able to use the indicator as a triangulation with other variables to allocate doctors to these regions where the helps the services are needed. So that's one of the uses of the HOI in Virginia. Next slide. Now, potential uses of the HOI, like I said earlier, next slide. Okay, the VDOT, which is the approach, they also have used the index to be able to evaluate their program. This is Vision Zero program, which is normally they call it a road safety performance. They were able to use the HOI to identify these neighborhoods that are having fatal injuries in the state of Virginia. And again, at the census tract levels, they were able to actually find out these neighborhoods and address the issue through intervention to reduce the type of injuries that they have been experiencing in these neighborhoods. Another issue is that during the Virginia passed the law of the Medicaid expansion, actually before the law was passed, we were able to actually identify which areas they should market the Medicaid expansion in Virginia based on the index that we created this index. But we use that the HOI with other variables to be able to pinpoint these areas to DMAS so that they can market the program to people who actually need the help of Medicaid expansion. And again, like I said, we have also used that for prescription deaths. Use it as we look at the Southwest Virginia area, you can see the difference from that to the northern part of Virginia. This index was used to identify these neighborhoods, and also that has helped the Chief Examiner's Office to be able to identify these areas for proper intervention. Our local health districts, Virginia has 37 local health districts, have used the HOI again to figure out which of the 13 indices are more influential in their area. If you look at here, this is the Portsmouth, an example. We're able to tell them the top 5 or top 6 indicators that they should focus on so that they can address the disparity in their area. And this again, when we did that, we also put on a map to show them, so you can see from this map that it's very clear that the indicator is actually tell them where they should be looking. So we look at where we have the big bubbles. That's the place that they should be looking. And again, this is also census tract level. You couldn't have seen this if you were to be in a county level. Now the question is, how do you replicate this HOI in your states? Well, we again we had to actually, our former director had to work so hard to get all the stakeholders on the table. So we had to consult most of the local health departments, and to come to the table, some of VCU, which is one of the universities in Virginia, were on the table. Some of the EMS was on the table. And again, so we all have to sit down to figure out and identify these indicators that we think affect health. And also, we also have to be sure that there are academic literature that supports what we're trying to do. And again, the indicators that we were trying to identify were more actionable. Like I said earlier, segregation versus race. And again, we wanted to make sure that they are consistent, that all the variables you can get all those variables at the census tract level on that. So those are some of the things that we had to consider when we're doing the index. And again, for manpower, you might need 1 or 2 EPI skilled with the geospatial techniques. It has to serve to someone that knows how to, because it's important to have someone that have that skill. And also do more investment, like putting on more than at least. We bought about the software, close to 30,000 software to be able to do that, SPSS modeler to do that. It took roughly about 6 months to be able to get this index done. And also, not only do we have some of the EPIs in the building, we also had people that give us a free advice from BDOT, that some of their technicians also help us to identify some of these variables. And again, I think that is some of the things that we've done in Virginia, and it's been very helpful, and we've been able to at least address some of these issues in Virginia and address disparity in Virginia. Thank you.
Thank you, Rex. We really appreciate your input. That was an excellent presentation. Now we want to turn to the Director of the Office of Health Equity in Ohio, Chip Allen. Chip, are you ready?
Yes, thank you, Deborah. Good afternoon, everyone. Appreciate the opportunity to be here and also to co-present with my friend Rex. Next slide. What I'd like to do really briefly is to talk about, the importance of the collaboration between the states. I also like to be able to talk about how tools like the Health Opportunity Index will allow us to really level set what we mean by particularly health equity concepts. Sometimes we get those key concepts confused, and this will help. Place really matters. I want to talk a little bit about that, and also talk about just how the Health Opportunity Index not only just really strengthens public health, but how it simultaneously allows us to address health equity. Next. So the way we got started is in 2016, I had an opportunity to attend a really important meeting that's sponsored by the CDC Office of Minority Health and Health Equity that Dr. Leandris LeBird she organized. And it really gave many of the offices of health equity and minority health an opportunity to come together. At that meeting, I had an opportunity to talk to then the former director, then Dr. Adrian McFadden. And we talked about ways on how we could actually work together, being that in Ohio, I didn't have a lot of resources to do advanced analytical work. And so we came up with a sense of a partnership. And she said, well, Chip, I know that you use market research data and analytic tools to do some of your work. So if you can show us how we can use that type of data, we can help you think through the Health Opportunity Index. And it was really just a wonderful partnership that was very mutually beneficial. Now, as I go through my next slide, please. A couple things I just want to be able to talk about is that a lot of times when we talk about giving people what they need to make data-driven decisions, local communities, they really want information to complement what they already know to help them thrive. Health and human service organizations need data to make important decisions so that they can use their level of influence to really create opportunities where people can be healthy. But we can't really leave out the business community. They need information to understand how they can be successful. And pretty much they can be successful when communities are healthy and they thrive. And so we want to be able to give all three of these entities information that they really need. Next slide. Now, as we go through these next set of slides, I'm going to be saying next a lot because I tend to use animation to really help drive home a number of different points. And when we start thinking about like these concepts of health equity, a lot of times what happens is we talk about health equity and health disparities and health inequities as if they mean exactly the same thing, and they don't. Next. Next, please. And so what happens is that part of the reason why we can get through some of this confusion, if we actually have the appropriate data set to be able to help us distinguish between a situation of what does health equity really look like in the real world? And the reason why that's so difficult for many of us to answer is because we've never really seen a map of health equity. We talk about health disparities, we tend to really understand that, but we really get confused when we start talking about health inequities. And so we want to be able to have a data set to clear up this confusion. Next. So when we think about how to advance health equity, there are really three things that we really need to understand. We want to be able to understand, for example, the health conditions that we tend to address. Where do they tend to exist at their worst levels? We also want to make sure that we have data sets that allow us to be able to really make these distinctions between key health equity concepts and how they're distributed through geography. And it's also important that we all know, for example, that low educational attainment and poverty result in health disparities and health inequities. A lot of times what happens is we don't know which of those social determinants of health really cause problems. And these social determinants are really much more dynamic than we tend to think about. And so the Health Opportunity Index really helps us work through these difficult situations. Next. So I'm going to, here's where we start getting into a lot of the animations. So I'll say next a lot, just try to ignore that. But one of the things we tend to do is we tend to prioritize, our work based on what we funded to do. But in the real world, the disease issues that cause health disparities and health inequities don't really follow our categorical funding line. And so we really need a new way of thinking that really reflects the real world. Next. So here is an image of Columbus, Ohio. And Columbus, Ohio is our state capital, is where the state health department is located. And I'd like to be able to show you what I mean about new way of thinking. Next. So here's what you see here. If you actually go through very, very valuable resources that are publicly available, like the Burfus 500 Cities Project, you're able to map by census tract a number of different very important health issues. So I've gotten anybody can actually create these same maps going to the 500 Cities Project. Now for the lead data and also preterm birth data, I actually work with my program partners to get lead data by census tract. And also I work with our biostats department to get preterm birth by census tract. Now the reason why we use census tract and not zip codes is because, as most of you all know, zip codes are primarily developed for the efficient delivery of mail. But when you begin to start to try to make decisions around health issues, you really need a level of geography that's designed to be homogeneous and consistent. So as we know, a census tract can have anywhere from 1,500 to 8,000 people with an optimal size of 4,000. So when you're looking at these specific levels of geography, you want to be able to use a geography where you can compare apples to apples. Next. So here, as you can see, some of these images on the bottom reflect data sets that are optimized for Columbus, Ohio for these different health conditions. Next slide. So if you actually take those indices and you say, tell me where I can actually find these conditions at their highest levels. Next slide. If you put that into a GIS program, you're actually able to map where these particular health conditions exist, in this case for Columbus, Ohio, at the worst levels. Next. So let's do this. Next. Let us take all these, I talked about this different way of thinking. So let's take all of these conditions. Next. And let's see if we can actually take the data and combine them as if they were one area. Next. Next. And then we'll use maybe a relational database, something that you all have on your desk like MS Access, to perform what's called a convergence analysis. Next. If you're actually able to put that through a simple database, and let's say we want to determine where, for the conditions that I just showed you, where could we find at least 4 of them at the census tract levels at their worst level, we would be able to come up with a report like this. Next slide. So one of the things we do is when we have these very serious health conditions, and we say that we want to find out where at least 4 of them exist at their highest levels, what does that look like? Next. This is Columbus. Next. And then these are the areas in which we can find 4 or more of those health conditions at their worst or highest levels simultaneously. Next. So when you run a demographic analysis of that, we'll see that we're looking at a population of over 114,000. Right off the bat, we see a disparity. Columbus, in terms of the Black African-American population, they only make up 29% of the population in Columbus, but they make up 54% of this area. You can see the other racial groups and also the ethnic groups in terms of their composition of the city. But then when you start looking at some of the other demographic characteristics, some other issues begin to come out, issues that make us think not just about disparities, but also inequities. So in Columbus, excuse me, and this is 2018 data, the unemployment rate is 4.7%. But in these areas, this combined areas is 7.5% unemployment. Now let's put this into context. We know that we just got out of one of the worst economic situations since the Great Depression. At the height of our recession, unemployment was 8%. So even though that unemployment was 8% then, in 2018, it is in these areas, it is 7.5%, which means that in the areas that have these disparate convergent health outcomes, the recession is still going on, in addition to serious health issues. Next. So again, it's not just enough to know where these serious health outcomes occur. We have to be able to detect what's really driving this. And then, of course, the Health Opportunity Index makes this possible. Next. So again, I really appreciate Rex's tutelage and also him helping me to understand this. I just want to go over what the Health Opportunity Index will do for you. Next. So it takes, again, these social determinants that we know impact health outcomes. Next. Rex helped me to understand, he would put those through the principal component analysis. Next. And once you do that, next, what you're able to do is to be able to understand how social determinants are related. And I just want to spend just a couple more seconds on this one slide that's just emerged. One of the things that the Health Opportunity Index helped us to understand is that while we do have very serious social determinants, they tend to occur in groups. So for example, when we look at the economic component, job participation, spatial segregation, income inequality for Ohio tend to occur together. When we think about the environmental impact, issues of affordability, healthcare access, walkability, employment, environmental or pollution, and population density, those social determinants tend to occur together. Now, this was a real game changer for us because when we think about social determinants, we tend to think about the ones, of course, that we know. We tend to think of poverty. We tend to think of healthcare access, but we never think about how these social determinants tend to happen in groups. So this was very important for us because now we have a new way of thinking about this problem in a way that we didn't have before. Next. So what does health opportunity look like in Franklin County, Ohio? Next. So when we this is the first time based on the Health Opportunity Index that we were able to really visualize health opportunity. So areas that are dark blue, individuals in those census tracts have the best opportunity for good health. And then as you go down the continuum, as the colors change from blue to the purple to the deep red, those individuals who live in census tracts that are colored in the deep red, Health Opportunity Index 0.1 to 0.23.4, they have the lowest opportunity for good health. Now, this is, again, a real game changer because it really allows us to understand where we should be focusing our activities, just like Rex said in his presentation. Next. So let's do this. If we can take those outcomes, those areas in Columbus that we know had at least 4 or more of those health conditions at their worst level. Next. Next. And let's just change the color of those areas. Next. If you actually take those areas and superimpose them on the areas that we know have poor health opportunity, one of the things that we actually now can see is that the health opportunity index really has been validated by other data sets. So in other words, those areas that tend to have the lowest HOI or lowest health opportunity tend to be those same areas that we can see these very serious health outcomes that these convergent health outcomes. So now that in a sense, the health opportunity index actually has been validated by other data sets. Next. So again, as I said, it's not enough to know that social determinants cause health disparities and health inequities. What specific social determinants drive these poor health outcomes in different communities? I want to reemphasize that because I want to show you just a few more maps. Next. So here's an analysis that I did in Cleveland, Ohio. For some of my colleagues in Ohio, these areas represent either Cleveland Heights in terms of census tract 141300, and then Shaker Heights, census tract 141400. Next. When you start looking at the health opportunity index and some of the information that Rex helped me put together, we see that in the Cleveland census tract of 119,202, folks in that census tract can expect to live to be 63 years old. And then in the other census tract, 81 and 82. So now we're talking about in less than a half mile, life expectancy that has a span of at least a 18 to 19 year difference. Next. Next. And next. So what I wanted to be able to show you is the population of those areas. Well, one of the things that, so while we understand life expectancy, the health opportunity index really uncovers some other information. It lets us know that the economic profile based on the scores that you see, it's really having an impact on some things in terms of life expectancy, income inequality, job participation, and segregation. So next. If we further examine this, we see that when we look at in terms of income inequality, the median income in the census tract in Cleveland is $23,000 versus $108,000 versus $123,000 in Shaker Heights. If you look at the effective buying income, basically how much money that there's in a community for them to purchase goods and services, we go from 14 million in the Cleveland census tract to 90 million to 132 million. So we talk about, even in terms of the incomes, we look at a 4 to 5 times differential rate. Next. 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 When we talk about job participation, unemployment is really significantly different in those areas. Next. And then we start talking about segregation. Well, one of the issues is that, and even in terms of wealth, 76% of the folks in the Cleveland census tract rent, and then you have home ownership, which is much more prevalent in those other census tracts. Oh, and by the way, remember when I used that other conversion analysis to talk about those health outcomes? Well, in the area census tract 119202 in Cleveland, there are 6 health conditions that are simultaneously at their worst levels. They tend to be diabetes, high blood pressure, prematurity, coronary heart disease, stroke, and cancer. All of those health conditions are simultaneously bad in that one census tract. And so now, not only do we really have a sense of what how people are living, we now know through the health opportunity index what's driving those conditions. And we have also a sense of the diseases that are occurring at their worst levels. So the take-home message, thanks to the Health Opportunity Index, says this, that we can go in and do a number of different evidence-based interventions. We can go in and do the best public health programs that we know how to do. But unless we address issues of income inequality, job participation, and segregation, everything else that we think we will do won't have the intended impact that we think it will have. That is what the Health Opportunity Index will reveal. Next. 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 So one of the things I just wanted to be able to show you is that when we start asking questions, well, what can we do in areas that have poor health opportunity? Well, the first thing we might have to do is we have to be able to think about how can we increase the median income level. There are things that we can talk about in terms of mixed income housing. We need to promote business diversification, enhanced training, educational attainment, and also we need to think about in the next 10 years, what do the city and county development plans reveal for that area? And if we were then to use the Health Opportunity Index, how could this information influence those city and county development plans? Because that is what really drives what's going on. There's one other thing I'd like to talk about just here really quickly. Some of you all may have heard about these, some of you all may have heard about the federal opportunity zones. So that is money from the Department of Treasury that is being made available to stimulate business development in certain communities. This particular census tract with the lowest life expectancy is one of those opportunity zones. So what we're going to be proposing is a Health Opportunity Index actually is made available to help understand what types of businesses could go into the area and what types of issues that they need to address in order to make sure those businesses are successful. Next. So one of the things as you all may have known from another webinar is that as the Ohio Department of Health puts out grants to local communities, we do so about $300 to $400 million a year. We actually have a health equity requirement that they have to address certain issues. Next. So based on the Health Opportunity Index, when we actually compel our local partners, says what specific groups have a disproportionate burden of disease, the Health Opportunity Index helps. When we say we want program interventions to be rendered in an equitable manner, a lot of times we tend to deal with issues like we'll have programs and say, well, we want to reach the most people that we can. Well, you don't give the same thing to every community because all communities are not similarly situated. And so now we have a tool that allows us to focus where we should be doing particular interventions. We also compel our sub-grantees to identify social determinants of health that are impacting the public health problem. Well, now we actually have a tool that for every census tract, we can determine which social determinant is really driving the poor health outcomes that they see. And then we believe that by partnering with those who can address those social determinants, we'll have better health outcomes. Next. So, multiple applications for the HOI. Next. Well, you can look at it in terms of community engagement. You can go into the community, listen to what they believe are, and understand what they believe based on their own experiences, what's going on, and you can give them more data with the Health Opportunity Index. For public health accreditation, many of our, not only state agencies, but local public health agencies are really having to deal with public health, either accreditation or reaccreditation. And for those of y'all who have or are going through that, there are specific health equity requirements in accreditation. This will help you. Strategic granting, grant making, or even if you're talking about the State Health Improvement Plan or State Health Improvement Assessment, next, you can use that because all of them at some point have an issue of health equity that needs to be addressed. Next. And as you think about health equity and all of these different public health activities and the Health Opportunity Index, it's really important for us to begin to start thinking about a model of health equity. In other words, what does health equity really look like in your census tract? in your county and your neighborhood. Next. And when you do that, you have to put that into the context of social determinants, health inequities, and health disparities. All of this is going on at the same time, and if we begin to change our way of thinking, and we can change our way of thinking with the Health Opportunity Index or tools like it, we can make some better data-driven decisions. Next. So, what is the future for the Ohio version of the Health Opportunity Index look like? For my version, I think there's 3 things we can do. Next. First of all, we can make the Health Opportunity Index more available to folks in the local area. So thanks to my partners in our Bureau of Informatics, they helped me visualize the Health Opportunity Index for the entire state. This is on our Tableau server, and we are getting resources and trying to work together to put this on our website, just like our friends in Virginia have done. Next. The other thing we want to be able to do is to help this to be able to inform what's going on in terms of those federal opportunity zones. So our governor has really talked about the importance and the opportunities federal opportunity zones. We believe this too can actually help inform what happens with that process. Next. I've already been working with my counterparts at the Department of Medicaid, the Department of Mental Health and Addiction Services, and the Ohio Commission on Minority Health to be able to use this same data set to help us really begin to collaborate in ways that we haven't done before. Again, it's not that health disparities and health inequities don't exist, but if we can use a common measure that can link other data sources to this understanding of what's really driving health, we believe that we can actually really begin to move the needle, not only in terms of one particular disparity, but a number of different disparities, because now we have a sense of what's driving those. And then, of course, finally, next, as I told you, one of the things that we do is we give out grants to local communities. I just attended a dashboard training such as Tableau, and we are now beginning from our local grants to collect information on where health equity activities occur. So if we can actually take that information from our local partners, put it into a dashboard, we can look at something like heart disease at its worst levels for Columbus, and we can now determine whether or not interventions for health equity are actually taking place in the areas where we know that we have the worst health outcomes for not only one condition, but different conditions. Next. So in some of our parting thoughts, I want to actually be able to again thank my friends such as Rex and the Virginia Department of Health for their ongoing friendship and professional collaboration. I always joke and say that if you need some help, befriend a really smart spatial epidemiologist, and that certainly is Rex. I need y'all to understand something too, that I've never met Rex in person. We have never physically met. So I think that we're like best friends over the phone. But the reality is that he has lended his time and expertise. And through that, we've been able to collaborate and I think strengthen each other's health equity program. Please remember that health equity can be achieved in a lifetime. You cannot do this work alone. Again, I am an under-resourced office of health equity, but that should not, and while that does present certain challenges, it should not define you. It didn't define me. When there was no way, we actually had to make a way, and we made a way by making friends with folks who could actually complement each other in terms of what we need to do. And then last, we wanted to be able to share the knowledge. That's what we've done. And because we share that knowledge, we've been able to come to you today with this webinar. Next. I just want to be able to thank, again, folks like ASTHO who provided this learning opportunity, Dr. Adrian McFadden, Rex, Justin Crow. I also want to thank Mildred Hunter. She is our Region 5 Minority Health Advisor for Region 5. And it was because Mildred put together a webinar like this, which featured Dr. Adrian McFadden and the Virginia team, that I ever found out about the Health Opportunity Index in the first place. And when I first heard this information through Mildred Hunter, I said to myself, this is an aha moment, and the rest is history. I want to thank my former CDC associate, Sarah Marr, the Bureau of Health Informatics at ODH to help me visualize it, and also my student intern, Chinozo Okachikawu, who was able to actually be able to help me with the slides of this presentation. With that, I will close, and thank you for the opportunity to speak.
Thank you, Chip. Excellent presentation. So we now have a little bit of time for folks who are on the line to join our conversation and ask questions or share lessons from their own uses of data. So if you have a question, please type it into the chat box. We did get one question already, which is, what type of weight did you use when combining and quantifying these profiles? And that was during Rex's presentation. So Rex and Chip, I wonder if you can talk about the weights you assigned when combining and quantifying the profiles in the original construction of the HOI.
Right. When you run the model through principal component analysis, it gives weight to each of the variables. So it's just like doing regression, what we call the coefficient. So each of them has a weight. You then multiply the weight times the variables, all the variables in there, and then sum them up. So each variable that was in the model has a weight allocated to it, and you just multiply that times the variable and then sum them up. So the weight is assigned based on the interaction effect of all these variables.
Great. We got another question. Can you define one of the elements that's used in the HOI is something called population churning? Can you provide a definition for that?
Okay, population churning is the population turnover. In other words, the inflow plus the outflow divided by the total population in the area.
So it's like the level of population, like the number of lives in that area?
And the number of people that are coming in to the neighborhood and those who are going out as a proportion of the total population.
Great. We also have a question about whether you can discuss or address any limitations that might exist with small populations.
Right, it's true. We normally, area that has a small population, what we did was that we censored the data. If we have, again, we only use non-institutional data. In other words, people in prisons, people in, prisons, military are not involved, so non-institutional data. So we have to censor any area that has a lower population that is, we think that is skewing the whole model. So all those outliers in the model were were censored.
Mm. And then we have time for one last question. Have either of you trained your local public health agencies or networks or departments on the use of the HOI?
Yes, we have done a series of presentations and series of seminars for our local partners, health organizations. We have done it for all the EPI, in the state of Virginia, done it for the other directors and stuff. So each one of them, at least they know the uses of the tool and how they can use it to improve health outcomes in the area.
Great.
And I'll just chime in that there are plans to provide some training for the Ohio Health Opportunity Index. The first thing is just really getting it out so it's really accessible, so that if you have a web browser, you can actually go in and then just be able to see what it looks like for your community. So, but to answer the question, we are planning on providing some other trainings and webinars for this once we get it more accessible. And then once that happens, we'll be working with like my partner, Wallace Burton, who is a local liaison to local public health agencies, to be able to get that information out on the training on some local calls. So we have just a little bit more infrastructure that we are trying to build in-house to be able to do that, but more training is coming.
Great, thank you. If we have remaining unanswered questions, we will be sure to send them on to our speakers and get responses back out to the folks who pose those questions. It is 2:02. I want to be mindful of everyone's time. I want to thank you all for joining our webinar, and I hope that you found the information useful. We will be sharing our slides and the recording. We would very much like to know your feedback about this webinar. There's a survey link on the final slide, and we would ask that you complete the evaluation using that link, and we will also be sharing that link again in follow-up email. And once again, I want to thank our fabulous speakers, and I hope that everyone who has joined us has a great rest of the afternoon. Thanks very much.